Welcome to the Healthy Careers Podcast, where we help healthcare providers succeed on purpose. We take a conversational approach in learning from others who have been there and done that. Join us as we share expert insights from real people who are just like you, because we believe that success isn't just a destination, it's an intentional journey, and you don't have to do it alone.
All right, everyone. Welcome back to the Healthy Careers Podcast. I'm your host, Madison Loomis, and today I'm excited to have Dan Coll on the podcast. He was a PA before being a PA was cool, and he has lots to shed in terms of insight, advocacy, his leadership journey, as well as how different challenges have come about in his career throughout the times and how he's been able to turn that into something super positive and how he gives back to the profession and career now. So excited to talk about all those things with you, Dan, and thank you so much for coming on the podcast.
I appreciate you having me today. Thank you for the invitation.
Yeah, of course. Awesome. So first and foremost, let's highlight your expertise because you've been doing this for a long time and it takes a while to build up, and you've been in the orthopedic realm the whole time, correct?
Yes, I did a few other roles, emergency medicine, covered other specialties in my critical access hospital as well. But the focus since coming out of school, I've always done orthopedics and some emergency medicine and some other surgical specialties as well.
Awesome. Great. And why did you decide to go that route versus other specialties coming out of school?
Before I went to school, I was a river raft guide where I started doing wilderness medicine and swiftwater rescue. And after college, went in and did ski patrolling. I still ski patrol now, but I volunteer versus being paid staff. There's a lot of mechanical things in the orthopedic side that I really enjoyed. But when I was doing my clinical rotations, I enjoyed the hands-on component. A lot of the injuries I saw between ski patrol and river guiding, a lot of them are musculoskeletal injuries.
Yeah.
And so,
that's true.
And a lot of them were things sometimes we could fix in the outdoors, like learning how to reduce dislocated shoulders, which was more common in some of the older paddling techniques and stuff for rafting and whitewater kayaking. And we've gotten a little better and safer at now.
Yeah, definitely. Whitewater rafting, I went for my first time this past year here in Georgia, which is nothing compared to out west at all. But there was a place here in Columbus, Georgia, and I swear that our river raft guide hated me by the end of that trip because the whole time we'd be going over like, what is it, the levels? Like there's level 1, level 2, level 3, level 4. We'd be going over the tiniest rapid, and I was just screaming my head off. And he's like, we're literally just sailing. You're fine.
No, it was fun. I had gone to a summer camp in junior high, and then when I went into high school, they actually asked me to start working with them. So I started guiding when I was 15, 16.
Very cool.
And kept doing it through college. And that's how I met my wife, through our outdoor program. And my son's now back at our college at UC Davis, and he's actually working for the outdoor program as a river guide as well. And all our kids are rafting.
Full circle.
Kayak. Yeah, it's fun.
Yeah, very cool. Great. And yeah, that was one of the most exhilarating times. I was just trying to figure out the physics of how these men were pulling up like 300-pound people that were on these rafts, And I was like, are you sure you can lift me? They're like, yeah, no problem.
Yeah.
But it was a good time. That's awesome. So you do a lot of volunteer stuff. I know you mentioned with a nonprofit, right? Tell us a little bit more about that.
We have a local 501c3 nonprofit that is advocates for outdoor access to the public and education and utilization. And so we have several people involved in the program. We teach things like leave no trace, vehicle versus self-powered travel. And I often help by contributing also some emergency medical things, like I became a stop the bleed instructor. And so for some of the local overland and off-road groups, we've done seminars on stop the bleed for controlling hemorrhage in the pre-hospital environment, learning how to put in tourniquets, packing wounds, those kinds of things, which people were super excited about, learning how to put on a tourniquet and not be afraid of using tourniquets, things like that.
I often think about that when I'm hiking of like, what if I get bit by a snake, or what if, I fall off this cliff, because we'll go and we'll adventure in Colorado and out west, and you've got to be prepared for those things. So if you're into that stuff, I would assume that's very exciting. Awesome. Cool. And I really want to talk about holistically your journey as a PA, the challenges that you've seen, because as I mentioned, you were a PA before everybody knew what being a PA meant and how that was utilized in collaboration with healthcare teams. So tell me a little bit about like first getting out of school and getting into a practice. You told me, off show, whatever, that you were the first PA within a trauma hospital. So how did you fit into that and really educate people on what your role was?
Sure. So probably just easier to start a few years before that. When I came out of
Sure.
school in 2001, I started working at a trauma hospital in Kern County down in the southern Central Valley, just north of LA. And it was the only trauma center between Fresno and Los Angeles, and so it was a pretty big catchment area and highway. Really enjoyed the trauma, worked in the emergency room as well. And then I followed my wife. She was an OB resident and changed residency programs from a UCLA program there to University of Washington.
Okay.
And jumped up north for a couple of years. And when she was finishing up school, we had a great offer. I had been on the funny part about how the world works, when I had been on a clinical rotation in Lake Tahoe, where we had worked between her applying to med school and getting into med school. I worked as a ski patroller, and she worked at one of the resorts while she was trying to get into school. But I rotated a pediatric office here, where I met the pediatrician while I was a ski patroller, and she took me as a student in PA school. And then she introduced me to the obstetricians and gynecologists who were practicing here when she heard that my wife was a resident and that we might like to move here. And her partners were a 2-doctor practice here in Truckee, California, in North Lake Tahoe. And they had literally practiced on their own. When one of them take a vacation, the other person would be on for a week or 2 weeks, 3 weeks. And they were like, you guys move here, you know what it means to live in the snow and work in the snow. Last 2 winters ago, we had 700 inches of snow. People are.
Yeah, that's a lot of snow.
we have people come to the area and think that the roads are plowed all the time and that it's easy to get to work. And there's literally times where it takes a 5-minute drive could take you hours depending on traffic and road conditions and snow. So, but anyway, they recruited her here. And when we moved to the area, I worked for about a year in a ER in Reno, Nevada. And I had been cold calling orthopedic practices because when I came out of school in Bakersfield, I worked in the ER and the ortho clinic. And then in Seattle, I worked in the Harborview Medical Center's ER part-time while I worked in an ortho clinic 4 days a week. And so when I came down here, I definitely knew I liked ortho, and I also liked emergency medicine. Yeah. And as things would go, I sent out my resume to all these practices in Reno and contacted all these practices, and all of them said, most of them said, oh, we are already staffed, or we don't have PAs, or we only have a few PAs and we don't have any openings. But one of the practice managers gave my resume, my CV, to the service line director at the trauma center in the area, who was looking to hire an orthopedic PA because they had a community staffed orthopedic trauma center, and it was a very busy trauma center. There's only 4 in Nevada. There's 3 in Las Vegas and 1 in Reno. And so we were the only one in the north and the northern part of the state. And we catch from the Oregon state line, Idaho state line, and eastern slope of California into northern Nevada. And so we had a huge catchment area. So they were recruiting, and one of the practices, the medical director of the trauma service, Dr. Bray, and his practice used PAs. And they didn't have a residency program, but they had a very busy trauma center. And they said, well, how can we staff the service line? Well, let's hire a PA. And so I was the first PA that they hired for the orthopedic trauma service. I literally wrote my own privileges. When we talk about learning and experience, it was a real eye opener for me because they told me what my job was. And then I read my privileges and realized I couldn't do my job with the privileges I was given. And I said, I work for the hospital system. You guys want me to do this, but this is what you're telling me I need to do, and this is what my privileges say I can do. Right. And that's where I kind of started learning a little bit more about advocacy as well, because even some of my privileges had language that was out of date to the state law that had already been changed, but the privileges had never been updated. And then I started working very closely with our medical staff services director. And she was fantastic, and she taught me a ton about internal operations, and I showed her all the current state laws in Nevada, and we rewrote my privileges. They let me collect from other facilities, and I wrote my own, and then I hired a partner within a year. Awesome. And we staffed this trauma center that was 550 beds when I started. And by the time I was leaving, it was 10 years later, it was 850 beds.
Wow.
And we had actually started an ortho trauma fellowship because we were so busy that the orthopedic surgeons recognized they could train orthopedic surgeons in trauma there, and they were accredited.
Right.
And they were a bit unique because they were one of the first ones to add business curriculum. They were staffed by all private practices, and they wanted residents to learn, our fellows, after training, to learn how to also run a business and be financially solvent.
Yeah.
And so Nevada at the time, the PA Academy in Nevada was fairly inactive. It was hard to get a hold of. Even the AAPA gave me contact information that was out of date. And when I asked him, I said, well, who do I talk to? Because I'd been in California originally, which had a very active academy. And even in Washington, they had a very active academy.
Sure.
And they said, oh, well, these are the contacts we have for Nevada. I'm like, they're all expired. And so
these people are nowhere to be found.
No, and so the academy gave me a few other contacts, and eventually I did get in touch and started working with them as just a contact and asking them questions about practice in Nevada and what I needed to do.
Yeah.
And ultimately, I became I asked to run for a director at large position in the Nevada Academy of Physician Assistants, and took that role. And one of the things they needed was a representative to attend and listen at the state medical board meetings, because even though the majority of the population in the state lives in Las Vegas, the medical board actually functions primarily out of Reno.
Okay.
And we had representatives in both communities, but they needed someone to go to the board meetings, which I started doing. And that really introduced me to some amazing people at the AAPA as well, because at the time we had Anne, who was their state advocacy director, and we had for the AAPA, and she really helped many state academies and members grow into those roles. She was fantastic, and she happened, unbeknownst to me at the time, she lived about 70 miles away from me.
Oh, wow.
And she worked remotely for the academy, and then she traveled all around the country. And she was truly their experts interacting with state medical boards. And so she was one of my first introductions, along with another person. Her name is Trisha Marriott, who was in their reimbursement department, who was very, very helpful for me when I had questions about finance and billing and state laws. And so both of them taught us a lot. And then we had some bad legislation and changes in our practice law in Nevada that required us to organize and come up with reasons why that wasn't okay, and to try to begin to advocate more for the profession in the state. Yeah. And there was a private university in Henderson, Nevada, teaching PA programs. But one of the things that really also helped the state of Nevada is when the University of Nevada, Reno, opened a PA program. Okay. And the chair of the program is one of our past presidents of the Nevada Academy of Physician Assistants, Brian Lau. And he's been a great advocate because Northern Nevada was known that people in that area who wanted to become a PA would have to go to Southern Nevada or go to another state, because they were part of the Western University Exchange program. But there were no state-based PA programs in Nevada. And as people know, when you go to PA school, a lot of times your job opportunities and where you feel comfortable taking a job is tied to where you do your rotations. Yes. Yeah. And so a lot of the people would leave the area and never come back. And so, because they were going up to Oregon and Washington or California for a lot of their training, and then they would stay. And so they developed this program, and they've been going for 6 years almost, and been involved with it for interviewing applicants, reviewing applications, and actually doing interviews for people who get through the screening process. And then I help teach their musculoskeletal radiology and sometimes suturing. And I was down there last week with their second years, refreshing them on splinting techniques and how we splint. It's super fun to be involved with them. And they have very engaged and active students who've been very involved in the state academy. And so being involved in the Nevada Academy drove my interest. And ultimately, I also applied for other roles with the American Academy of PAs. And I also became involved with the PAs in orthosurgery. And then Dr. Bray was a president of the Orthopedic Trauma Association. He was one of the first private practice. There was like one other private practice orthopedist in that what was typically an academic organization.
Mm-hmm.
And he helped me set up with Dr. Archdeacon from Cincinnati, another great PA advocate who did PA and NP education around Cincinnati. But they set up a program for the OTA to create foundational ortho trauma training for PAs and NPs. We set it up during the annual meeting, and that's been going on since 2012.
Very
that meeting's
nice.
continued to grow, so it's been super fun. So the education side, but then I also applied for the National Quality Forum, was looking for a PA representative who practices in a rural area.
Yeah, I saw that. Yeah.
So once I was here in Truckee, we are a critical access hospital with 25 beds in a town of 17,000 people. North Lake Tahoe has about 40,000 people in the whole northern area. And then we catch to 6 counties in 2 states and about 100,000 people in total. And we have 2 other critical access hospitals that feed to us who don't have surgical services. Mm-hmm. And so to the north of us, an hour and a half, there's 2 other smaller hospitals. Since we're all California based, we get a lot of their California based insurance as well, because they can't go to Reno. And then the National Quality Forum led to some great opportunities. Spoke to the Senate Rural Health Work Group on PA utilization, because there was still some federal laws that were not great for PAs, as particular Medicare regulations for paying for services. PAs were at a disadvantage for a long time, where Medicare said they could pay nurse practitioners and physicians directly.
Yeah.
But PAs could not be paid. It had to go to their employer, which created a lot of confusion when tracking the work that people were doing, because the bills would come back and they weren't necessarily sure who provided the services, and split shared visits. But also direct payment bill allowed the bills to be submitted under the PA and clarified things like part-time and locums work, which ultimately it had been sitting as a bill for a number of years pre-COVID, and then it got attached to the COVID omnibus bill. And they changed the Medicare regulatory process for payments to PAs, and now you can't have direct payments. So it's very clear you can be a 1099 employee and do contract work, when before it was always a bit of a gray area. But it also made employers who were hesitant to use PAs and didn't know how to necessarily pay them in that relationship. Now that barrier is gone, and it's the same structure as as paying a nurse practitioner or a physician for their services, which has made some neat opportunities.
I think I think that's the biggest change, because you look at the discrepancies between, like, there's this ever-growing battle, and I've seen this, and I didn't know about it for the longest time, but when you talk to like an NP or a PA, and if a practice will post, like, we want an NP or a PA, right? And within orthopedics, more so you see PAs from a surgical component, because a lot of times they have more of that training than, you know, an RN who maybe was in the ER or wherever else. But, you know, you look at the differences between it, and it's like this ever-growing battle between, like, oh, the NPs are taking our jobs, or the PAs are taking our jobs, or they have more autonomy than us. And, you know, I had somebody on this podcast, Tracy, who's great at explaining, you know, if you're autonomously seeing patients and you're billing the same things as the physician, then there's no reason why you can't be getting paid for that. And I think for a long time, PAs were seen as the undertaking rather than being a collaboration. And so now it's like, you know, you can actually measure what you're producing. Before, there was no way to do it. So not only when it comes to a perspective from a business standpoint to look at it and say, oh, the PAs are bringing in this amount of money or whatever, but you personally as a PA can say, hey, I've produced X, Y, and Z, so that when you go for your raises, or when you go for a new job or for that bump up, you actually have data to prove, like, this is what I've done, which I think is so key for just, you know, that next step in making sure that PAs are paid and fairly.
So it's to tip my hat to my nursing and nurse practitioner colleagues. You know, my mom was a nurse, my mother-in-law was a nurse practitioner, a certified nurse midwife. But I think the reason they've been more successful at times historically is that they had often tied to nursing lobby groups, and the nurse practitioners were tied with them, and they had a very large voice, large membership, and large voice, and they were organized, very organized. And I think that I've seen through my career, the numbers of PAs practicing increase. When I came out of school, I think there was closer to 100,000 PAs, and now there's over 170,000 PAs, and we're teaching 10,000 PAs a year graduating, if I remember most recent data saying. And so the state academies across the country, if you look on LinkedIn, there's the postings about things like the licensure compact. We're seeing this momentum build. We're seeing these state academies really promote the practice much better than we did in the past. Utah recently passed the law with a certain number of hours. You no longer required a collaborating agreement, supervising agreement. We're seeing these multi-state compacts for licensing that now will make it so much easier for people to apply in one state and possibly work in another. I just recently, I volunteered with the Nevada Academy. I volunteered with the American Academy of PAs and the PAOS and OTA, but I just recently signed up in the last couple months. I became part of the professional practice committee for the California Academy of Physician Associates.
Okay.
And they have, we have the largest population of PAs practicing in the country from the last data I can recall. And so they've done a really good job of advocating. And one of the issues actually is still a billing law in California for our version of Medicaid. It's called Medi-Cal.
Okay.
And they have a billing policy that says we can be listed as the performing provider, but they still require that it be billed out under the supervising physician. And then in the last few years, they changed the law fantastically. We have now what are called collaborating agreements. So we've gone from being supervising physicians to collaborating physicians, and a big improvement in our reducing our administrative burden for the physicians that we're working with in the state. And that was a big victory with State Bill 697. Hopefully I say that right, but that was because there's quite a few numbers and letters, but the Senate Bill
sounds good to me.
Yeah, I'm sure my colleagues will correct me. They'll correct me if I get it wrong, but it really was a big change in the state of California. But now they have a proposal to fix the Medi-Cal billing issue, and that it be billed directly to the provider of the service. And to your point about invisible billing earlier with Medicare policy, this Medicaid policy in California makes it look like the bill, when it's paid, was done by the supervising physician or collaborating physician, not the PA. And so it's very hard in especially a small hospital like my own, where we're not as sophisticated for our revenue cycle services and what we can do to pull out that data and see who actually did the work.
Right.
And so then therefore they hide your work a little bit. And so it's definitely a concern that when someone's looking at how much we're contributing and whether we're covering our costs or being profitable, those types of things, they're not getting good information in, so they're not getting good information out. And that's something I learned a ton from the American Academy of PAs and being involved with them and their reimbursement committee. They have Michael Poe runs the service line now, and Sandra Palma, and they are amazing resources. And when people are like, well, why do I want to belong to AAPA? I say just alone for the reimbursement and advocacy information that you can get that will make you more successful in your practice. Ultimately, in our hospital here in Truckee, the small hospital, I was brought on to help reorganize the inpatient orthopedic care while we were working with a private practice that ultimately the hospital bought. And I was the director of the service line before we integrated with the practice. And we had to do a lot of work on tracking and understanding our revenue and our cost. And it was very challenging, because you recognized that a lot of even our revenue cycle folks didn't understand how to bill for PA and NP services well. And you point out, hey, we've missed this revenue. And they're like, well, we don't have enough resources even to go back and rebuild those things. And you're like, really? You're just going to, and they're like, yes.
Skip over it. Yeah.
And so in rural communities, we really look at, how can we use PAs and NPs to bridge the access gap. And there's just so much now as the state laws have been evolving that are really allowing PAs and NPs in those areas to maximize their contribution. And the us versus them mentality you mentioned a little bit earlier. I did want to say I was just at the American Academy of PAs Executive Leadership Conference. February was in La Jolla. And one of the keynote speakers was they sat down with the nurse practitioners president and the American Academy of PAs presidents. And
they fought. No, I'm kidding.
No, just literally two big recliners, big cushy chairs at the front of the room with a couple hundred people there who represented leaders across the country of major organizations using PAs and NPs, and had a conversation about how it's not productive to compete with each other, and instead, how can we help each other both promote these roles for PAs and nurse practitioners. And
100%.
You mentioned orthopedics, and there's definitely regionally in many parts of the country, there are variations on what services NPs versus PAs are doing, also based on the local training programs and what they're producing and keeping in those areas. But a lot of people don't realize, I'll put on my hat, I was the medical liaison for the AAPA to the American Academy of Orthopedic Surgery until I recently termed out. But when advocating for PAs and ortho to them, I remind them that orthopedics is the second most popular specialty now for PAs in practice. So family practice is about 16% of PAs, and they say between 9.5, 10% of PAs practice full-time in orthopedics, which is over 15 to 17,000 PAs.
Yeah,
and there's
incredible.
About 32,000 full-time practicing orthopedic surgeons, depending on the data you read.
Yeah.
But the majority of them are over 50, and they've recognized that they are not going to train enough orthopedic surgeons to match the retirements that's coming, the surge that's coming. And there's been a lot of conversations about how do we keep orthopedic surgeons in practice. Instead of just retiring, can they transition to part-time or reduce roles? How do we augment them?
Right.
And so there's a lot of discussion as well. And I have great conversations at these conferences. I've done a couple of their instructor course lectures where we had panels of PAs and physicians talking about how do we expand access to the orthopedics care with highly trained people who may not be physicians, but who support the surgeons. When patients ask me, how do I differentiate myself? The majority of my practice is outside the operating room. I can do pretty much the same tasks and procedures that I can as my surgeon. And my goal is that I should only be doing services that otherwise would have to be done by a physician or a surgeon, meaning we're not being asked to do tasks that normally the medical assistants would do. Or things.
Right. You're not a glorified medical assistant. Yeah.
Or you're not a scribe. And that the one thing I can do surgical procedures under local anesthetics. I just currently can't do things under general anesthesia, nor do I say I want to. I've worked with over 40 orthopedic surgeons and 23 plus years of practice. And I really, really enjoy working with a variety of different surgeons and different specialties and learning from them. And I say it 23 years in, if I'm still not learning every day, I'm doing something wrong. Because
there's so much changing too in orthopedics. Like you look at these procedures with minimally invasive stuff that you can recover within, 2 seconds after surgery. And you're like, whoa, what do you mean? I can do jumping jacks 10 minutes after my hip replacement.
Right.
So it is an exciting time. And I think too, and I think we've talked about this a little bit, within what I do, we primarily focus within orthopedics. And from my own standpoint, number one, transparently, it's because I have a family member that is an orthopedic PA. And so understanding from his standpoint, about that and being introduced to that. But also, I'm super into fitness and wellness. And so, as you said, when you're into that stuff, you see a lot of injuries of people that get hurt in the gym or, I do CrossFit and I've seen plenty of CrossFit injuries. I've had my own injuries, right? Where you go and, you work with orthopedic and or PTs and of that realm of people. And you think about the aging populations, right? Of people that, even in my gym alone, there's this hilarious guy who's like, you keep working out because I've got 2 bionic hips and this and that. And, so many more people with that boomer population getting into the 60s and 70s, they are going to need orthopedic care and they're going to need it to where they can get back to their daily activities and living. And I think that it's just such an interesting shift that we're seeing in medicine because placing PAs in orthopedics, placing physicians in orthopedics, there's a lot of people that you talk to are coming out of fellowship and they've got all these new fancy things that they're doing. But then you can talk to somebody that's 80 years old who's still a spine surgeon and they're like, I'm doing this until the day I die,
Yeah.
So I think it's just a fun specialty overall.
I would say I've had my own fair share of orthopedic injuries and surgeries, and
Yeah.
definitely I joke at times with my younger PAs to be able to counsel patients. You don't have to have all the same surgeries as they do, but I've had quite a few of them,
Yeah.
and so we have a very active population here in North Lake Tahoe. I have 60,
Mm.
70, 80-year-olds who are skiing 5 to 7 days a week. They're
Wow.
downhill skiing, they're cross-country skiing, they're hiking and biking in the summertime. Pickleball has been fantastic for
Oh,
orthopedics. Yeah.
yes,
Um,
pickleball. Oh my gosh, the
yeah,
craze
yeah,
is
yeah.
unreal.
We our local CrossFit gym is actually owned by the husband of one of our OR nurses, and so we always joke with them that it's job security, but we also some of the best, fittest, most
Yeah.
active staff members and people in our community are all members of the gym. You know, they do a
Yep.
fantastic job, and they're very good about they joke,
Prevention.
prevention, and then also when people are injured, they're also very good about modifying activities but keeping people
Right.
able to do them. So
Yeah.
no, I think it's fun. We joke sometimes it's a bit unusual with our population
Mm.
locally because they are so active and people move here to play. But we
Yep.
also, because we feed from such a large area, we also feed from some communities that are definitely much more, much less active by choice, but by
Sure.
occupation.
Yeah.
We have to the north of us large communities that are based on agriculture and lumber industry and
Mm-hmm.
other industries like that that are very physical. We have a huge resort communities up here that require a lot of staff to keep the hotels and the facilities open. And
Yep.
for them, if they can't work, they're out of income. And
Yeah.
so it's not a cheap place to live. And so
Yeah.
there's very different motivations. At times, people focus on the luxury homes but the service providers, the people who are working in the restaurants and the hotels and the ski resorts,
Mm-hmm.
all need to work, and they need to get back to work as soon as they can when they're injured.
Yeah. It's the same, honestly, where I live. I'm about an hour outside of Atlanta, and we're in a very rural area that is blue collar workers. So, construction companies and manufacturing. And I think there's maybe 2 orthopedic specialty practices here. And most of your specialty places, it's few and far between. It's like, hey, you got to drive to Atlanta to go see that person.
Sure.
And from a talent acquisition standpoint, it's also very difficult on being rural and trying to get the best of the best who want to come out here and work. Cause it's like, hey, we're in this podunk town in the South, and we've got a Walmart and a few restaurants. But it's interesting because then I recruit for some larger areas, like you look at San Fran or you look at Tampa, and it's like there's people lining up out the door because orthopedics is just so sought after. So
Yeah,
it's
it's
interesting the
interesting.
disparities.
Well, and in some of those areas, it's tough to recruit as well because they're so popular that they pay less. And so
Mm-hmm.
I know some orthopedic surgeons who tell me in Southern California and some of these communities that which are very expensive and popular places to live, but they also come with a lot of competition for the roles that are there, and they come with lower compensation.
Yeah.
And so it's, sometimes living in a rural area, maybe making a little less, but your cost of living is significantly less. And
Oh, yeah.
your quality of life may also be somewhat better. We have a fellowship trained orthopedic trauma surgeon, 2 sports medicine docs, and we have a generalist who went through a strong program where he got a lot of trauma, foot and ankle surgery.
Mm-hmm.
Um, but at the same time, we were one of 3 hospitals in Northern California to get a new robot system for total knee replacements. We were able to
Cool.
advocate with our hospital, and our hospital foundation said, "This sounds great. We'll pay for the robot. You guys bring it in. It's different. No one else, even 30
I would
miles
love to see that.
east of us, was using it, and they're using
Yeah.
older style robots." And we said, "Hey, this will definitely distinguish us."
Mm-hmm.
And our surgeons recognize when things need to change, and some of them went and trained 15 plus years ago on doing direct anterior total hips with
Mm-hmm.
a shorter recovery time. The results are the same in a year. Everyone needs to know that, but their recovery time was quicker, and patients had mobilized quicker and were happier, and they've been doing it longer than anyone else in our area. So it's been fun
Yeah.
to see that they can be that agile as a small practice
Yeah.
as well.
Yeah, definitely.
So
Yeah, I
yeah,
think there's kind of back to what you were saying too with the rural thing and then the NPs, like that is a majority of the practices out here is there's a few MDs and then you go and you don't see an MD. Like their waiting lists are out the wazoo. You see an NP and some people have a problem with that. And I'm like, I don't have any issue with that. You know, like I'd rather be able to spend 30 minutes and really talk through what I'm going through than feel like the doctor's running in and running out because you're one of X amount of patients. And,
Sure.
you know, especially in primary care, family medicine.
Well, and even in orthopedics, you know, you bring up rural communities. There's several Western states where they talk to orthopedic PAs who are in very rural communities, and they're running a clinic because the community could not function for musculoskeletal care, couldn't support an orthopedist, but they have relationships with orthopedic groups. Maybe they're working in that rural clinic for the orthopedic group, or they're referring patients to that group when they actually need a surgical intervention, but they're doing the initial evaluation, they're doing the injections and the physical therapy, they're saving those people the travel time. And then when they do send them to an orthopedic practice, they have a package of someone who's ready for surgery and understands that they've done everything else that they can before surgery. Or they have surgery and then they do their follow-up care in their community. One of our orthopedic surgeons here in our practice stopped operating, and then he reduced his practice, but for the last 15, 20 years, he's been practicing 90 miles north of us 1 day a week. And so he sees the patients, he evaluates them, he does the treatment, and he sends them to us for surgery, and then we do the rehab. And he wants help in his practice, and it's a non-operative practice. And he's talked about, well, why don't we have one of the PAs coming there to help him as well? Because we could do outpatient, we can do very much the same things. And,
they can, the PAs can handle all that. Yeah.
And he's worked with us and he knows what we know, and he was comfortable, and we're exploring all those things, you know, as we try to keep coverage in that area. And especially as he gets later in his practice, he's not interested in working more, but he's like, yeah, if we need more help, let's bring in a PA or someone who's not worried about needing the surgical volume, because then if you're bringing in another surgeon, a lot of times they need the surgical volume, and their hospital is really not set up right now to do any surgeries for orthopedics.
Right.
So, yeah. But they still keep their patients and do the workup and get great care.
Yeah. It's cool how the healthcare thing is evolving and how people are getting so creative on ways of providing that care, which I think is vital. And I think that PAs allow places to do that, because without that, it's like people are just going to go without it. Right. You know, so
I think it's deceptive when you look in California and people think we have these areas with huge population densities. But California is a massive state, and we have so many communities that are not only geographically isolated, but for us in the mountains, these communities, when we have snowstorms, I told you we had 700 inches 2 winters ago, and this winter we're doing very well, but we're not as much as that year. But those patients can't travel it's very difficult to travel far to get their care. And so if they can stay in these mountain communities like we provide a critical service. And they also like being in a smaller practice. And we have a lot of patients who could go to some of the bigger practices, and they've said, we'd rather go to a smaller practice. We feel it's more appropriate to what we're used to and what we like. And everyone knows your name and they remember you. And you don't feel more like a number. And the volume is not as much of a focus. And because we're smaller, we're able to do that and manage our costs and our overhead and be financially a very significant contributor to the health system as well. But only recently did we get really good, to your point, really good RVU and production information and charges and collections. And it's been super exciting. We went to Epic in 2016, but we're so small, we couldn't afford our own. And so we have a fantastic chief information officer, Jake Dorst, who had practiced in huge health systems across the country. And he said, well, how else can we get you the most current EMR? And he started looking at other health systems and how to host us through other health systems. And ultimately, he tied us to Mercy in the St. Louis area, which is like 44 hospitals. And we became a satellite for them.
Oh, very nice.
We even went around and offered to other community hospitals, hey, if you want to hub off of us into Epic Mercy, then we could do that. And he set that up so that we could also become a center point for them on the West Coast.
Yeah, that's great.
now we're still learning this many years later and gaining a lot more information about what we can get out of Epic and how do we build that
use the
into Epic.
data. Yeah.
And that was one of the great things at AAP at ELC were 2 talks on informatics. And it's fascinating right now to see these PA leaders, like Wake Forest PA leader was speaking about it, as was Oshner's and another from Hartford, Connecticut. They all gave fantastic presentations on how they're using their EMR to better document and attribute the contributions of their PAs and their NPs. And they talked about things like being able to figure out what specialties spent the most time having to go through past medical records in the chart because maybe the chart wasn't prepped as well, and they could see that every visit they were spending a lot of time going through the chart. And they said, well, how do we make you more efficient? How can we prepare the chart? So when you're seeing these patients, you're not having to spend as much time digging through the chart for the information you need. So really interesting thoughts.
And there's a lot of I'm a data nerd. I used to recruit in tech too. So I have a huge love for that. And just as a business owner, I love looking at numbers because I'm like, that's how you tell a story. Without the numbers, everything that you're saying is just kind of your perspective of it. But I used to recruit in tech, and you see so much of this AI stuff coming out now too, where it's software that overlays on top of your, system that then can just shoot out random stuff that the second that you see the patients, you don't have to spend but 10 seconds going over it with them, 30 seconds, because it's all right there. And it's in a very digestible, efficient way for you to take that information. And even just looking at it too, from a perspective of, talent acquisition of, if somebody comes and works with us, how long is it taking us to actually see our ROI on that person? Right. How much are they bringing back to us in terms of their ROI? And I think all of that, and then coupled with all of this AI that's happening in healthcare tech, is going to be super fascinating over the next few years to see, once that's implemented, how much more efficient healthcare can become. And I think that helps to kind of mitigate the push with reimbursements decreasing. And so this push to see people quicker and taking away from patient care. But if we can implement something that makes patient care better, well, then we're at least hopefully moving that needle a little bit towards more on, the outcomes versus just the invoice.
No, and it's interesting you say that. I was trying to pull up the information, but one of our reps one of our implant reps was exploring other revenue streams with a job change, and he joined an AI company that is now helping hospitals look at their billings and making sure that they're billing correcting and capturing all their services they can. And one of his biggest targets right now are these rural hospitals. So he's been soliciting Nevada Rural Hospitals Association. They have there's similar ones for California. And to your point about being financially viable, making sure you're getting paid for the services you're already providing, which is a conversation we've had here before in our rural hospital, is do we need to see more patients, or do we actually need to get paid for what we're doing?
Right.
And so he joined a company called Jory, and they look at your billings and
Jory.
they make sure.
How do you spell that?
Jorie. And they will look at your billings and make sure that you're actually capturing all the revenue you should be. And so what they've done to get facilities interested, they will screen your billings for free for a period of time.
and they're like, hey, look what you lost out on.
Yes. Yeah. Super, super interesting. And and so when you talk about applications of AI and being a numbers nerd, I went back and got my MBA in health administration, because when I was the service line director, I realized, advocating for full reimbursement and having our revenue cycle department actually bill for the services we're doing. And when they weren't, how do we rectify that, or how do we educate them on the opportunity? And it's been super helpful to be able to talk about things like contribution margin and returns on investment, and getting people to understand. And you can't expect a PA or a nurse practitioner to produce as much as a physician in the same hour when you sometimes don't give them the same number of space, rooms, appointments, support staff. But at the same time, I point out that, well, maybe they're generating more money because they cost less in a short period of time. And so at the American Academy of Orthopedic Surgery, when I gave one of those talks, I had a great surgeon stand up and he said to me, "Well, I see 6 patients an hour." And I said, "That's fantastic, sir. That you've obviously gotten very efficient." I said, "But how many patients in an hour does your PA need to see to break even and cost you nothing?" And he said, I don't know, but I expect them to see 6. And I said, "Right. But what you should ask first is, how many do they need to see before they cover their cost? And then how do you also incentivize them and benefit both of you to see more and be happy about it?" And afterwards he took me aside and he's like, "I never had even thought of that. And that makes so much sense from a business mindset, because they cost about a third per hour or so, depending on the specialty, 25% to a third in a lot of the specialties, and in primary care, maybe 50% of the same cost." And he said, "But I hadn't really thought of it that way." I said, "Yeah, figure it out, and then help them understand too." I say to PAs and NPs all the time, "What do you cost your practice?" And they say, "What do you mean?" I'm like, "Well, what's your benefits on top of your base? What are they paying for your malpractice? What are they paying for everything else? Your licensing, all those things, add it all up. And then that's how much you cost them per hour if you divide it over that year. And then, figure out how do you cover that. And then maybe how do you have a conversation of, hey, I'm making more. I'm making more. I'm covering my cost, which, or I'm multiplying revenue over my cost, which in my specialty, at least in orthopedics, it's very realistic that, if I make the OR efficient, we flip rooms. That was something we never did before with our surgeon. And literally today, the OR can't keep up with us we did 4 total hips, and they couldn't keep up with cleaning the room and setting up the room for the next case because we just don't have that many rooms. But we make our rural OR very, very efficient. And in a much shorter period of time, we're generating a higher number of cases than we used to. But it's still not the most efficient way sometimes to use us, because we can generate often more money in the office seeing several patients in an hour than what we make assisting. But when you bundle us into what the surgeon's generating to the practice, and you recognize that without us contributing, then he couldn't be as productive as he is. And all of a sudden, the practice manager and everyone else goes, "Holy cow, you're right. His production has gone up with you guys there. He's working fewer hours per day, but he's doing more work in those hours, and he's happier because he's going home at 1 or 2 in the afternoon, and you guys are finishing discharging and seeing all those patients." But he's done the same amount of cases that he used to go till 6 or 7 at night and go home exhausted and frustrated.
Exactly.
And
and it's interesting too when people try to fight back, because sometimes I'll talk to an organization and they'll tell me that they want to hire another physician, and sometimes you look at their model and it's like, why aren't you hiring APPs instead? Because if you have a PA that is handling, and we'll take orthopedics, for example, post, a surgery, a hip replacement, and they're doing the post-op care and they're handling the clinic, I think where a lot of places go wrong, and when I see from a talent acquisition standpoint, when I'm like, hey, I understand that you haven't utilized an agency recruiter, that you haven't looked at the data, but, I'm seeing that you're seeing a 50% growth, but your average tenure is less than 2 years. So something's going wrong here, right? And it's that they don't have any type of bonus outside of, maybe they get some first assist money, but in a clinic, if they're needing to see X amount of people per day, 30 people per day, well, then you're making a lot more than what you're costing. And you've got to be incentivized and motivated for that. And in any other industry, like you look at recruiters that are on my team, they make a base salary. They have to make that base salary back. And then once they do, they earn money. They earn commission on what they're producing. Right. You look at any other position where money and profit is being handled, they're being paid for it. And I feel like healthcare professionals finally having that data can say, hey, wait a minute, how come I'm not getting paid more than $140,000 when here's what I'm making the practice? And if I weren't here, oh, by the way, here's what the physician would have to be handling. And they wouldn't be able to be handling more of the higher paid things like surgeries, et cetera.
Sure. And what I would say is there's, at least in the orthopedics, especially world, in 23 years of practice plus, I've watched, and they talk about it in the orthopedic professional literature as well. We have a major transition going on. our surgeons are becoming employed. The MGMA says 9 out of 10 graduating residents wants to be employed, not own their own practice and operate their own practice. But historically, in a lot of the private practices, more of an eat what you kill kind of model.
Yeah.
The harder you worked, the more you made.
Mm-hmm.
And now, when they're becoming employed providers in health systems and organizations, sometimes those organizations are good about maintaining some incentives so that people who choose to work harder do get paid more.
Mm-hmm.
But sometimes the surgeons will point out, and when they're in a salaried model, that there's not a lot of incentive to work harder. If you're getting paid for doing less, you're getting paid more for doing less work. And then when you do more work, you're not necessarily getting paid a lot more.
Yeah.
And so I think that's a really challenging thing. And when a lot of health PAs are employed in large health systems, they really struggle to differentiate the specialties. And that's very apparent because they bundle orthopedic PAs into, our primary care PAs are making this much money, right? But
two different things.
I work another, I technically work another 50 to 75% on call.
Right.
That, there's 5 of us staffing our service. If we worked hourly, they need 8 people to staff what we do with 5. And so how do we recognize that? And so I wouldn't phrase it, originally started out mentioning, hiring another PA versus a doctor. And I think in orthopedics, at least right now, we don't have an excess number of surgeons, especially in my rural areas. So when I talk about people practicing in a rural environment, but it applies just as much in an urban environment, is how do I make the doctors as efficient as possible? And I'm also professionally satisfied. And how do I see these do the things that I like to do? And so I started a nerve cold treatment clinic where I do all the cold treatments for post-operative pain. So after surgery, patients have lower pain, but also patients who aren't good surgical candidates, or patients who've had a total knee or joint replacement before. I can do nerve treatments to reduce the pain if they're a smaller population that sometimes still have ongoing pain. And that for me has differentiated me. We joined the Own the Bone Association for osteoporosis recognition and prevention. Orthopedic practice, it's ripe. We see these patients who go, wow, you had your second hip fracture and you've never had a DEXA scan, or you have known osteoporosis in your chart and you've never been treated for it, and we're seeing you for a fracture. Okay, let's call this out to our colleagues who can see this for you in primary care or endocrinology, or some orthopedic practices that are very interested, even at academic centers. They're using PAs and nurse practitioners to run their osteoporosis clinics. And they're not only treating fractures, but now I talk to some of these PAs and NPs, and they're now doing bone optimization before patients have joint replacements. And they're like, hey, you have really bad bone, but you need a hip or knee replacement. We're going to send you to our osteoporosis clinic. They're going to treat you for 6 months or a year and get you ready for surgery so that you have a better result after surgery. So the opportunities there are fascinating.
Yeah, I haven't heard of that.
But
that's cool.
A pitch again for like specialty organizations and advocacy, right? The American Academy of PAs does a very good job of a salary survey across their population, and they put in information, and they have orthopedics in there as well. But the PAs in orthosurgery, the subspecialty, the largest subspecialty for surgery in PA practice, they have their own survey that goes into a super high level dive. RVU generation, different compensation models, call obligations, clinic structures, what procedures people are doing. Even things like, does your practice even show you what you generate? There's like 50% of practices don't share.
They won't, because they don't want you to see.
They don't share what you're generating in RVUs or reimbursement. A lot of practices just roll your call compensation into your base, and then others pay for it. And so they collect this data over their membership, which is over, I think, 2,500 PAs now or more, which is fantastic. It's a great data pool. And then if you're a member, you get that as part of your membership, or if you're not a member, you can pay for some of that data as well. But it's a way they drive membership as well. But it's a huge service because you can look through that and say, you know what, our practice has the opportunity to do this, or we do this well. Sometimes when I interview at other places, or I've looked at other jobs and I've been like, wow, tells me I'm doing well at my job for this benefit or these things. And, maybe we can ask them to do this, and everyone would be a little happier.
I see that a lot from a talent acquisition standpoint. Like, a lot of people And I don't mind it, right? Because that's why we're here. But people will reach out and they want to know, like, oh, what's the pay? Or like, what is the bonuses and what is the structure? Or I have clients that they're like, hey, we can't seem to retain our PAs. And I'm like, okay, well, what's your structure? Like, how are they paid? Oh, well, we just give them a flat salary. And I'm like, okay, well, they're expected to see a certain amount of people in the clinic. Yeah. Are they on call? Yeah. Are they first assist? Yeah. I'm like, okay, like I know why.
Yes. Yes. That's always a question when I get, is like, is this a new position or is this a vacated position?
Yeah, exactly. And I mean, some places have figured it out and they've been able to retain talent. And I think that is the best way you can do it, is to educate yourself on like, okay, the places that are retaining, I mean, clearly your practice, I would assume you've been there for a long time. They're treating you well enough for you to stay there, and orthopedic PAs are in demand, so because everyone has figured out like, oh crap, there's not tons and tons of orthopedic surgeons we can hire.
Sure.
But every year they're pushing out, like you said, 10,000 new people that, if orthopedics number 2, most people are open to it when I reach out to new grads.
Yeah, orthopedics is definitely an interesting specialty. There's very few postgraduate training programs. And when patients ask about PA practice in orthopedics, I point out there's 10 fellowships now for orthopedic surgeons that are recognized. And that orthopedic surgeons are doing 5 years of postgraduate training for their residency, and then 9 out of 10 of them are doing a fellowship. And another 10% are doing a second year long fellowship. And so we, luckily being in a smaller community, we have a pretty broad practice. I have friends who literally only do total hips or only work for a hand surgeon, and the hand surgeon rarely needs an assistant in the OR in their practice. And so they're mainly in clinic doing evaluations and pre and post-op care. Versus I have a friend who worked at one of the fellowship training programs, and she was critical and their microscope and micro neurovascular stuff that they do, and that she does go to the operating room a lot. And you mentioned that, the data information. Like, I had a really interesting conversation last week with Tricia Neen, who was at Sullivan Cotter, and she helped Sullivan Cotter set up a advanced practice provider database that's like 8+ years she was there, and now it's being run by a PA named Zach Hartzell, and they do an amazing job of aggregating practice information from major health organizations and systems across the country. And so they now have one of the largest banks of PA practice information. What's interesting to me, they have great information, but when I look at it, sometimes I think about comparing that with even like the PAOS survey, and you can tell a lot of the information they have is from health systems, but not necessarily what private practices.
It's so different.
There's still very large orthopedic private practice groups in many parts of the country that pay very differently for their PAs and nurse practitioners. You think of big systems like Ortho Carolina and Ortho Indy that have done fantastic jobs. You talk about PA leaders. Mike Harvey was at Ortho Indy, and now he's at Forte, and he's their clinical operations officer. And he helped set up Ortho Indy's urgent cares in many of their practices. Camille Carey is at Peninsula Orthopedics in Baltimore, and he's their CEO. He's now gone into being the practice CEO, and I run into his PAs, and they really recognize the advantage of having a clinical leader, and that he really recognizes and values their contribution to the practice. He'll be speaking at American Academy of Orthopedic Executives at the end of April with Mike Harvey and Dennis Rivenberg. They're all going to be speaking about how to optimize use of PAs and PAs in their practice.
Good.
It's really neat to see.
That.
You are?
I was going to.
Okay. I'm trying.
But, I know. It's so hard nowadays to escape, as a small business, taking time away from recruiting and providing for my clients. But I'm hoping that next year they're actually in Atlanta. So they'll be in my backyard. So it'll be much easier for me to come and go to that.
Yeah. It was, to your point, it is tough. We need 50 hours a year as a CME to maintain our national certification. But for instance, my employer here gives us 40 hours of covered time off to do that.
Oh, awesome.
And so that's fairly good. But they recently reduced it to 24 hours. And I said, you want us to be board certified, but you're reducing us to 24 hours. Because they said, well, we're raising other people up who hadn't had that same 40 hours, which I had advocated for when I was a director. But I drove myself to San Francisco for the American Academy of Orthopedic Surgeons.
Oh, yeah. How was that one this year?
It was good. It was in San Francisco, and it definitely a lot of logistics for people and people coming in to the city. And so next year it's going to be in San Diego, and San Diego is always one of their highest attended events. And so I know they're excited about it as well.
Yeah.
But I drove from that conference to La Jolla to go to the AAPA conference, and I did that all on vacation time. I had to burn my own vacation time to get the CME and use the time. But I enjoy that, but you talk about the challenges as well, right? We want our surgeons to be board certified, and we want our PAs to be board certified, but we know we're not giving them enough time off to actually maintain their board certification.
Yeah. Come on.
So that's always one of those interesting challenges as well.
I think they should give you that PTO time back. If they're listening, you should give it back.
Yeah. But I'm just kidding. I am hoping to go to AAOE for the first time actually ever for me this year.
Oh, awesome. Yeah. I've heard it's fantastic. I had one of my clients who went last year when I was in Florida, and I'm kicking myself for not going to that one because it was a trip to Florida.
Right.
But yeah, this year I won't be going. Chicago is just a little bit too far for me with everything that's going on. But I've heard it's, tremendous. And there's a lot of people that go to that and who have actually, I guess I don't mean to speak ill on any organization, but have said they enjoy that more so than the AOS, which I know AAOS is a little different in terms of who goes, but
right. I mean, for someone who wants number stuff on HR and employment like you do, that's AOE.
Exactly. Yeah.
For someone who wants current clinical practice things, and
exactly,
AAOS is helpful. And then what's really nice is they've reorganized the meeting. Dr. Matt Proventure is the chair of the annual meeting committee, and he recognized some of the challenges, and they shifted it in the week and took it off the weekend. And then they bookended specialty days last year on the front and the end, and this year on the end, to try and shift the load. And so not only did I go to the annual meeting, but I also was able to attend the OTA and the Foot and Ankle Society's combined specialty day meeting at the end, which was actually a fantastic day. So
cool. Yeah, it sounds like you do a lot of conferences. I'll have to message you after to see which ones you think are the best, because I'm just now getting into that since my business. I started 2022 end of that year. I'm just now getting to a point where I'm like, okay, I can go and for a few days network, because it gets to a point too where you want that face time and you want to learn from the people and what they're doing and what are the trends and all of that. So I'm glad that you're having the chance to go to that. And you'll have to go next year too in Atlanta.
Yeah, maybe. I know I enjoy not only the educational, but it is, again, to your point, it's the networking and the education side as well. I like teaching for the PAOS and the OTA. And I taught for the AOS and the AAPA. We did the radiology and the injections workshop last year in Nashville when we were both in Nashville. That was a great opportunity. And so I enjoy that part as well. And it's really where I've actually built more opportunities, like things that led to me volunteering with the AAOS. And I was on the annual meeting committee as a volunteer, because they don't even have it in the bylaws yet for a PA to participate, but they said we want input. And now I'll be volunteering for a subcommittee where they're looking to develop new curriculum for the annual meeting.
Very cool.
So fun things like that. And I think at this point in my career, I super enjoy my clinical care, but at the same time, I find it really helpful when I'm like training at the local PA school or helping practicing PAs at these meetings. When we do these sub meetings, I really enjoy that part of the education as well, and getting them up to speed and getting them confident and competent, and so they can feel like they're getting the best contribution.
100%. Yeah, no, I think it's fantastic. All the volunteering you do, you're much more altruistic than I am. Makes me feel bad about myself.
I don't know. Awesome. I feel like sometimes it's a bit selfish, because I do get, I enjoy it.
Yeah. If you enjoy it, and I think that all goes towards advocacy as well. Like I always say, advocacy is not always standing outside of the White House with a picket sign. It's sometimes just doing what you can with where you're at. And I think you've proven that point, right? That you can always teach somebody something, learn from somebody else, and if it's all going towards the greater good of making people aware and pushing for things that make sense, then you're doing advocacy in that.
Yeah. Thank you.
Awesome. Yeah. Cool. Well, this has been fun. I have enjoyed learning from you and all the things I truly didn't know about some of the stuff you were talking about. So it's been helpful for me, and I'm sure for listeners as well. We'll have to have you come back on once you've gone to some of these conferences and learned new things, but thank you so much for joining us today.
No, I super appreciate it. The one thing we didn't talk about that I think is really fascinating right now too, and came up a bunch at AAPA's executive leadership conferences, the use of professional coaches, executive coaches. A lot of the leaders were talking about executive coaching. And so that's something I just started exploring as well. And so there's a surgeon who does professional coaching for other surgeons, and he set up a training program through the International Coaching Federation, so you can get a coach certification. And at the meeting, I learned how many of these PAs who are in leadership roles and who were doing advocacy or other additional activities had utilized coaching services to make them stronger in their roles and help their career ladder. Yeah. And so, I think you talked about that on some of the other podcasts, but I think that's really an interesting thing that's happening now. And I'm seeing more and more PAs get into that world as well. And I think that's another way to give back to the profession and help others be successful and grow in their careers and increase the impact of the profession too.
100%. Yeah. I actually do some HR consulting with a coaching company. They have a platform where they hire coaches more so on like the leadership development for enterprise companies. But I find mentorship and learning and all of that, like it is best taught through somebody else that has been there and done that. That's why I have this podcast, because I'm like, I could sit there and read a book about everything to do with orthopedics and PAs and physicians, or I could just invite somebody on and talk about it and learn it directly from them. Well, and that's more fun.
The person I mentioned who's retired from Sullivan Cotter, Trish, she set up a consulting business where she does do some coaching and organizational consulting. And she coached the lead APP at Ochsner, Emily, and Emily has now set up at Ochsner. They now training internally their own coaching in their PA and NP leaders, and so that they can she increased their satisfaction and career ladder and development of their APPs, and so they're developing coaching staff in the APP department as well. Super
fantastic.
Stuff. Anyway, it's another whole other thing to talk about.
No, I know. I love that stuff too, from like performance management with like planning for who's coming up and training and promoting within. Like I could talk about that for hours, but
and the business world is so much better at healthcare, but there a lot of organizations are recognizing that PAs and NPs as clinicians can make very good clinical leaders with that insight of a perspective of a clinician.
100%.
And you're seeing places like Stanford who developed their own fellowship and leadership institute through their advanced practice council, and other organizations are doing similar things. So it'll be interesting to see that momentum grow.
Yeah, I'm looking forward to it as well, because when I started recruiting in healthcare when I was in college, it was like there was no leaders that had any clinical perspective whatsoever. And now it's like most of my clients are clinicians who took over lead APP roles and or moved into C-level positions where, you know, they earned their seat at the table, and now they're the ones that are making decisions that are not just some healthcare executive.
Right. No, I'll have to share offline some of these other PAs contacts at these organizations, like the CEO in Baltimore and Mike and Ortho at Forte now in Indianapolis, or Zach Hartzell at Sullivan Cotter. All PAs, all in different leadership roles and ways they've really grown the profession. So
definitely. Perfect. We can definitely connect about that. I'll have him on the podcast.
Fantastic.
Great. Awesome. Well, thank you so much for your time. This has been fun. And to everyone else that's listening, if you want to connect with Dan, he is all over LinkedIn. So you can connect with him there. And if there's anything else from the coaching perspective, Dan, that you want to share with folks, I'll make sure to link it here in the show notes as well.
Perfect. Yeah, I'll get to the information for SurgeonMasters, which is who does the coaching. Perfect.
Yes, I've actually heard of that. Perfect.
Yes.
Okay, awesome.
Take care.
Thanks.
Thank you so much. Bye-bye.
Thanks for listening to the Healthy Careers Podcast, where we provide a platform for you to ask hard questions and get real answers. If you enjoyed this episode, don't forget to subscribe and share it with your friends. Stay tuned for more episodes every other Friday at 7 a.m. Eastern.